Hello, we are Carlos Parra
and Alejandro Sánchez, laboratory technician, and we came to talk about full arch and passivity of zirconia total prostheses.
And we are here to shed a little bit of light, aren't we, about how are all the current workflows in full arch. It is quite challenging today to achieve a completely passive 100% accuracy in capturing a full arch using intraoral scanners. And today we come to shed a little bit of light to see how we can give you some tips to help you in this step that we have every day in the practice. Right, Alejandro?
The arrival of new digital materials such as zirconium or nanohybrid materials means that this type of prosthesis we see on the screen, the demand for our reconstruction's passivity is significantly higher than previous estimations. Intraoral scanners show discrepancies in scanner scaling while preserving their meaning and length and ensure that our reconstructions do not possess the appropriate level of passiveness. In our cast analog prostheses, the passivity was less demanding as the metal supported a majority of the deviation, reducing the need for additional adjustments of casting, impression taking, and the expansion and contraction that the material underwent during the production process. These materials, such as zirconium, require a much more exquisite treatment when it comes to this consequence of passivity.
Totally agree. The advent of the new zirconia with the rigidity that this entails increases the risk of material fatigue and fracture, and therefore of the material itself. If there is no 100% fine passivity, which is not usually the case when using digital systems, because there are margins of error that must be compensated for and you have to work very carefully. That is to say, no matter how good the scanner is or how good the latest generation scanner is, if the operator's hand and the flow is not clean, it will cause a series of errors, as Alejandro said, which will be transmitted to the laboratory in the final zirconium restoration, which when it finally enters the mouth with that tension or with some tension will simply cause the patient's occlusion forces to cause that material fatigue and therefore those fractures.
But no longer even with the occlusion, but they are materials, as in the photograph, which can even break, not even in use, but simply at the time of giving the screw connection of the prosthesis. That loss of passivity in the fit with the connection, they break instantly, but because that deviation causes the seat is not correct, right?
Hence the need to have a tool that would facilitate, on the one hand, the taking of the impression for this type of full arch work, and at the same time reduce or try to limit the series of biases that we were sending to the laboratory with the intraoral scanning of a completely digital arch. Echoing this call, IPD developed a special transfer for complete arches called scan transfer, which are the ones you are seeing on the screen and that come to remedy all those compromises and errors that we had clinic and laboratory to work, right?
The word play with the product definition of scan transfer. It was a bit of a play on the benefits of the traditional analog transfer of taking a tray print and the digital word of scan to be scanned as well. What is the benefit of this peculiar piece that really reminds us a little bit of a temporary abutment piece? We will even see later on that it can have a very peculiar use related to immediate loading. This is a transfer which allows it to be splinted in the mouth or through a previously designed fry.
As Alejandro was saying, this type of tool supports all the flow that we had in analogical. Why is it that if I was able to transmit passivity in an analogical way, I was able to transmit a series of tests to the laboratory? Now in a digital way, I had lost them. Well, that was the demand that we clinicians had been making to the industry to be able to correct that series of errors. But at the same time, we needed a tool that would allow us to facilitate the whole system for taking the impression, because sometimes in edentulous patients with a very resorbed bone profile or a high floor of the mouth or palates that were too deep, it was complicated to take the impression of these patients with the complete arch. So we also needed a tool that would help us to solve a series of problems. What is the first item we discovered when we used the scan transfer? Well, unlike other transfers that we use digitally, this one does not require us to scan the entire body. I don't have to do an exhaustive scan of my entire cylinder to transmit the position or the XYZ axis of that implant to the lab. I simply need to scan the head, that most prominent part of the scan body, which is the most coronal part. I need to scan it well so that it will be able to locate in space, right, Alejandro? the position of my implant, which also makes it much easier for us from the clinic. I don't know how you see it from the laboratory.
The only top concept referred to in the slide is based on the fact that by dividing this element into two parts, we could see the main body, the striated part, as the part that would allow the clinic to splint and turn it into a body only for joining parts. And the top of the Onitop would be a conical piece with a digital library associated with it that allows with a single top pass on the roof of the scan body in a single pass, in a single reading, without having to go around the piece to occupy the maximum view of it and capture it in a single easy pass. It has an irregular geometric figure so that the reading continuity passed from one part to the next. Having this irregular surface geometry, the scanner does not confuse the upper surface of one with the other.
This facilitates the clinical part and makes it much easier for us to place the implants inside the mouth and transmit it to the laboratory so that you are then able to work with the different libraries.
It is a versatile piece, logically designed to improve the passivity and improve the reading of any intraoral scanner, since it would facilitate the reading continuity and avoid the possible deviation that may occur at the time of the scanning protocol. Logically, on arrival at the laboratory, this required that this element could be managed with any current design software. On the screen you can see that any current software would have that library that would provide any associated IPD system in scan body. We could work with custom interfaces, we could work with temporary abutments, we could work to make an immediate loading probably and customize temporary abutments, cutting them and treating them so that at the time of placement directly in the clinic, it would be a quite versatile and comfortable maneuver.
Another thing that the clinicians who work in the digital flow also demanded a lot was that this scan transfer should not only have libraries available for all the systems, but also that it should be easily captured by the different scanners on the market, because sometimes in the same clinic we have different brands of scanners or we have different models of scanners depending on the clinic where we go. We also needed this tool to be effective and to be easily captured by the different scanner models on the market. We also worked a lot with the development department to ensure that the surface, roughness and dynamics of the scan transfer could be easily captured by the different elements currently available on the market for intraoral scanning.
As I said before, the piece is designed to have a versatility of use. In general, we are talking about a scan body with the facility to be splinted. We can treat it in different ways. It can be splinted in the mouth and scanned in the mouth, or it can be splinted in the mouth. It is sent to the laboratory, which would obtain a passive model of it, with which you could then test the passivity of your T-base of the final reconstruction. Use this model as a cementation passivator, and we can have the possibility, as we said, to trim those provisional abutments and finish an immediate loading on a passive model.
Of course, it is a tool that will help us to take the impression immediately after surgery and therefore be able to perform an immediate early loading with our patient, or of course for taking an impression 3 or 4 months after the healing of the implant for the definitive rehabilitation that we are going to support and that we are going to design for the patient's restoration. We were talking about the fact that the scan transfer is a tool that combines many tools in one. It is a multi-tool. It is a clinical element that is going to help us to try to bring together different clinical needs that we have been demanding from the industry. And one of them is to be able to have radiographic control, a control of the radiographic passivity of what we are scanning. It is very important to know how the scan body adjusts to the platform of our implant, and for this it is essential to be able to make those radiographic controls that we required.
As a curious element to highlight in these slides, we can comment that logically the radiographic control of the adjustment for taking the impression is fundamental to guarantee that what we are scanning is in its correct position. But IPD brings even more value. This versatile tool is so versatile that the location of the screw, when we finish screwing this piece, the screw is designed and manufactured to be flush with the scannable head, so that at a glance we really detect if we have the element connected correctly.
Of course, having a visual element to warn that it is not in the correct position makes the adjustment process much easier, especially to know if it is passive and if it is correctly positioned. As we were saying, it is a tool that is going to try to group different functions, as we were saying, analogical in a digital format. The first of the tools we were asking for was to be able to splint, to be able to transmit that splinting. Not so much for the fact of establishing how a splinting was performed analogically to avoid the rotation of the transfers in the handling with the silicone or in the dragging towards the casting, but it will help us to facilitate the continuity solution when scanning, as we mentioned before, in patients who are extremely edentulous or have a floor of the mouth that is too high or simply have mucous membranes that are complicated to capture. This type of splinting will help the scanner not to get lost and continue along its line of capture and significantly reduce the deviations, especially in arches where there is no palate, such as the jaws, in which the scanners tend to close these meshes in a natural way when shaping the mesh, and therefore we dragged margins of error at the end of the mesh due to this constriction of the mesh. Well, now we have the ability to splint these scan transfer with different methods, as we like in the clinic, either with materials or medical, as we see in the images on the left, or with acrylic materials such as Duraline with a silk in the image on the right, to try to transmit all that splinting not only to the scan, but when I have finished scanning, I can disassemble it and send it to the laboratory, because thanks to that, Alejandro, in the laboratory,
the double action that we receive with that splinting in the mouth is very reminiscent of that analog splinting that was done to contain, from the word ferrulize, to contain the analogical transfers for the removal of the tray, so that there would be no mobility that would later be transferred to my definitive model or the rotation of the transfer itself. In this case, it is a totally different concept. It helps to the continuity and gives a double version, which would be the obtaining of a passive model that could give me to validate my reconstruction after the design and the management in milling machine, or in the placement of the T-base in a passive way in the model. In the previous figure, we can see how in that versatile part that IPD proposes, in the clinician's eagerness to splint this tool, he came to block with so much material that they could run the risk of hiding the scannable part of the only tops. No? So that this does not happen in the splinting maneuver, IPD proposes and incorporates a protective cap to the scannable head, which we see in the picture, which are those white caps, which provide protection so that the doctor can splint without any risk of that area being visible both in the clinic and in the laboratory, so that it can be scanned again. And the repositioning of the scanner would make a definitive and correct situation of the scan body in the mouth. We propose an exercise where we can validate and see the real operation of the scan transfer. The scan transfer proposed in the clinic as a scanning tool without splinting would be not giving the correct use that it proposes to the ease of the continuity of the reading and the accuracy of passivity. On the screen you can see how I do an exercise of a scan without splinting and a scan with splinting, and we can see the existing deviation that exists from one to the other. Deviations that we can be talking about 40, 70, even very large deviations in microns due to that deviation and that deformation suffered in the arch.
I totally agree, Alejandro. It is illogical to think that scanners are 100% efficient, because they are not, just as they are also subject to the operator's hand. So we are not going to be equally efficient every day, and the scanner is not going to be equally efficient either. It is subject to a lot of biases that can intervene and alter that measurement, hence the need to be able to make this measurement more reliable thanks to passivization systems. So with this type of tool with which I am going to be able to splint the scan transfer, my objective is not, as you said, that it does not rotate or move, but that there is a parallelization or a fixation of the scan body that I can then transmit to you in case there has been any error during the process of incorporation of the digitalization to the scanner. It will be corrected in the laboratory with those deviations or with those analyses of the deviation that Alejandro makes later in his laboratory, so that way we would only be taking or making an impression of our patient in the first appointment. But we would also be doing a digital passivity test at that first appointment. We are combining two tests in one. We are reducing the capacity for error in our work, and we are making our work much more efficient, and at the end of the day it goes well and we don't have complications.
Be efficient and also contribute. We know that in the market there are several ways to passivize our digital print taking. There are different ways, different techniques with different systems, even computerized. But what IPD proposes in addition to leading to a good situation of the prosthesis, is also proposed in an economical and efficient way. In terms of time, no complex technical maneuvers are required or costly equipment in the clinic, which in the end adds to the inconvenience of the treatment.
And I would add one more thing. In the end, it is a workflow that is already familiar to clinicians, because all those who have already been taking impressions in an analog way will not find it strange to splint a transfer or to splint a scan body. The process is the same, so in the end it is a friendly tool that does not complicate the normal clinical flow. On the contrary, it is a flow that was already introduced in the clinic, so it does not require a learning curve. It is simply applying a technique to a digital system to try to favor and facilitate even more the final protocol, right?
And with this, we hope that we have clarified many doubts about passivity and especially about digital printing, both clinical and laboratory.
If these types of tools come, as we were saying, to help clinicians to make our lives easier, to make our results much more predictable, then any doubt that may arise, if you encounter any problem when using them, you can contact us through the IPD platform, or you can find us on social networks where we will certainly solve your queries and your doubts about time and life leave us. It is a pleasure to have been here with you today and to have shared the stage with Mr. Alejandro Sánchez Toro, from whom we learn something every day, and it is a pleasure to have shared time with you.